Hi, I'm Alison Galbraith. I am a general pediatrician and a health services researcher. I'm from the medical school. I'm not a health economist, but I think a lot in my work about the impact of health insurance design on cost and affordability from the perspective of pediatric patients and their families. So, So a lot of policy and research focuses on individual adults, but I think it's important that we also think about children and also families because there are intrafamilial effects that we need to think about. For example, Medicaid eligibility varies across age, and so within one family, there might be people who have different types of coverage. There are spillover effects. Adult Medicaid policies often have spillover effects on children. For example, ACA Medicaid expansion had some positive spillover effects on having increased enrollment of children. Mostly we think about low-income children as having Medicaid, but it's important to also think that about 20% of children have coverage through commercial payers. And in Medicaid, there's no cost sharing, but in commercial payers, there's pretty high cost sharing. And so that's another burden on their families, and that can create intrafamilial trade-offs and other spillovers. So to get at some of these questions, I'll tell you about a study that we did, the AFFORD study. It was a mixed methods project, and we looked at experiences in high deductible plans for children and adults. And we looked at this with asthma as the exemplar because both adults and kids have it. There's a lot of morbidity, and the meds are expensive. We did quantitative studies using insurance claims from Optum and difference in difference methods. We found that there was some modest decreases in preventive medication use for important asthma meds when people switched from a traditional plan to a deductible plan. Compared to those who stayed in traditional plans. And then conversely, when high-value meds had cost sharing removed from them, we did see increases in use, modest increases. But interestingly, we didn't see any impact on asthma flares, on outcomes. And so that was puzzling. The narrative is that you would have increased cost, decreased use, and worse outcomes. And so we explored that a little bit with some qualitative studies. A qualitative study of adults with asthma and their kids, and we found that people reported that they really prioritized getting their asthma care. They needed to breathe, they needed their meds, and so they would get their meds and they wouldn't pay the rent or they would go into debt. One person sold their plasma. And they talked about making trade-offs using a bunch of other criteria. People would get their child's asthma meds and they wouldn't get their own hypertension meds. They might fill their meds and then they wouldn't put money into college savings. Or they would get their asthma meds and not get something that felt less acute like their cholesterol meds. So another group that I think also is important to think about when we're thinking about financial burden related to health insurance is adolescents. Adolescents have one of the highest rates of uninsurance. They are at risk for coverage churn as they turn 19 and they lose eligibility for Medicaid. And so the next phase of this research is to look at the impact of coverage churn on outcomes for adolescents and how a lot of policies recently to extend continuous coverage affect churn and health outcomes, and how redetermination policies and administrative barriers might affect these outcomes, especially because adolescents are learning how to navigate the healthcare system. So thank you so much.